Okay, so can we please sit down and stop making noises? We are going to have a great cases from US next. So I would like to call my co-moderator, Dr. Asad Khan. And chairpersons, we have some virtually Javed Suleiman from USA, Bilal Murad, Javed Chunio, Prag Doshi, Paul Mahoney, and Salman Arai. These are going to be virtually from USA. And from here, I'm going to name whoever is here: Dr. Zafrul Islam, Tahir Sagir, Dr. Rosli Muhammad Ali, Dr. Azhar Kiani, Dr. Farhan Tayyab, Nader Khan, and Dr. Najib Azam. Can Dr. Professor Hafizullah come also, please? And Noman Nasir.
Anthony, show us what they're seeing over there. I don't want to see ourselves. I really don't.
Okay.
Thank you. My earpiece?
Mirage?
I know.
लाइट पड़ रही है ऊपर पता नहीं चल रहा हो गया
Okay, so we're going to start with the first live case. Rajiv, good afternoon.
Here, how are you?
I'm good. I'm glad
Can you
that
hear
we
me?
can hear each other and see each other. Okay, so we have a great
Long Island, New York.
Seeing that what you're thinking,
panel of
look what they're seeing
experts
up top.
here.
They're seeing only the foot camera.
We have people from US and also
Welcome from
people
Manhattan,
from
New York.
here.
I'm Rajiv.
Camera, not seeing the boom.
Raj, who's our cath lab.
All right. All right.
मेरे ख्याल है बाकियों को म्यूट करने पड़ेंगे
Rajiv, 1 second. Rajiv, 1 second. Can I request all the panelists who are virtually to mute themselves? I'll really appreciate it. And when I ask them, they can unmute themselves. Thank you. Okay, Rajiv, sorry, go ahead.
New York. From Manhattan, New York, I'm Rajiv Jauhar. I'm standing next to my colleague, Pervez Miraj, Ali Yassin. Our team is in the control room. I think we have a terrific case to present to Pakistan Live 22, and I think it will highlight a lot of issues that were discussed last hour. Ali, you want to present this? Sure. Ali, our tip fellow will present this.
All right, good morning and good afternoon to you all in Pakistan. So our case involves a 9-year-old gentleman with exertional dyspnea and abnormal stress test who was referred for coronary angiography. You go on the next slide, please. So his medical history, as you can see, is significant for CAD with a total of 3 stents to his LAD and SIR, type 2 diabetes, hypertension, hyperlipidemia, end-stage renal disease on dialysis, and include aspirin, carvedilol, losartan, nifedipine, and atorvastatin. So as you can see, a very robust anti-ischemic regimen. Next, please. Yeah.
You're seeing our slide.
Stress test was done at,
We are
an
not
outside
seeing your
facility.
slides. We can
Sure.
see you, but not your slides.
No, no, we do. We're only submitting our boom cameras there right now. We're not,
Share.
So, but maybe you can just tell us the history without
You
slides.
guys, it's no problem. I can just tell you. So,
good?
an outside facility, and it showed high-risk features, basically anterior and inferior wall ischemia with hypokinesis of corresponding wall segments, essentially in the anterior and inferior walls. His EF on the stress
Seeing it to the top. You know, these things. They weren't
65%.
so able to switch it. I think it's not sticking.
Mentioned previously the predominant symptom that he had was dyspnea on minimal exertion. So CCS class 3, probably around 20 to 30 feet when you get dyspnea.
So that's our presentation. We're going to show you the coronary angiogram from today. Can you show the angiogram from today, please?
No, actually, Anthony, could you switch to our live screen here? The
Anthony, to our live screen.
We are not seeing the angio.
So the angio really showed very calcified left main, distal left main with a tight ostial cert and a tight proximal LED. The patient was considered for bypass, but given its comorbidities, they surgery refused.
Can we see the angio? Because we are not seeing the angio. We are just seeing you.
yeah, so it's so let's just go to this. Let's go to this. Let's cancel our share for a second. Let's go to MacLab. Let's go to. Let's clear this. Okay, so what happened?
Watching the Pakistan Live conference, it's been a terrific job. I think kudos to amazing conference.
Rajiv, I don't know,
Do it.
there are
Just do it.
multiple Zooms
let
connected
them
or
do
what?
what's on.
Your voice is really echoing a lot. We are having difficulty in understanding the voice and we are not seeing the angio also.
Bashir, can you hear me?
Yeah, I can hear you, but a lot of echo in the voice.
I think we disconnected too.
No, we can hear you. We can hear you.
So? Okay. Sorry, we have to restart something. We'll be back on in hopefully a couple minutes.
Okay.
You know, technology is a great thing, but
Yeah, it can be a problem too.
it can also
Work slide.
If you do get the slides up, you will see it's a great court case. A great court case to present.
Get the case up. I'm curious from the panelists and from the folks from sitting in the audience. When you have patients that are surgical turn-down cases, how do you typically address it? Is it addressed? Do you typically present them as PCI patients, or do you say, you know, maybe medical management may be best? Obviously, it depends on the angiography and the difficulty of the case, but in general, when you have these surgical turn-down cases, I'm curious from the panel, what's the mechanism in the cath lab among the interventionalists?
Now, do you see the slides?
Not yet. Now we see it. Now we see everything. Rajiv, we can see now.
Can you hear me? Can you hear me? This.
We hear you, but there's a lot of echo in the voice.
Usually in Houston, right now I'm visiting family in England, so it's kind of like odd time zone wise. Anyway, so to answer your question, my feeling is generally, if you send someone to surgery and they get turned down, then that doesn't mean that's where the treatment stops. If you thought they were sick enough or needing of revascularization, I think you apply the same criteria, because really, when you take these surgical turn down patients, you can almost always do something to improve their perfusion. So my feeling is that every surgical turn down should be presented to the heart team. And if you don't have a heart team at your center that does complex PCI, perhaps send them elsewhere, but have someone who's an expert at complex PCI take a look and give you a second opinion.
We by chance, do you see our slide now?
Yes, we do.
So I'm on Zoom and I do see your angiogram.
Great.
So the angiogram, as you can see, it shows a distal left main, osteocircumflex. By angiography, you can see there's a significant bit of calcium, and both the LAD and left main. Can you go next picture, please? Here on the next picture, you see that the LAD is diffusely diseased proximally. There's a significant distal left main lesion. And again, you see some calcification, but we can't really appreciate how much calcification, but we're suspecting, given his end-stage renal disease, he has a lot of calcium in his left main. Given the fact that he was a surgical turndown, we had you mentioned, we had a heart team approach to discuss the best options. So for the panel over there, what would you guys do next?
Okay, let me ask the panelists what would they like to do. So it looks like there's a distal left main disease, proximal LAD, osteocirc, there's a lot of calcium. So, so Nawan, what are you going to do in this patient? What do you think?
Everyone hear me?
This is Bilal. I think that all complex PCI cases like this, in order to strategize what's the best way of doing it, I think imaging really helps us to understand the pathology and what kind of technology we'll use, how much calcification there is, and that adds to your assessment of risk for the patient's procedure as well. So in this case, I guess I would start off with imaging to understand that. The other question that I have is, what's the patient's LV EDP and LV function?
Nicole, what was the LVDP today? It was 8 to 10. It was low.
Okay, Dr. Rosley, what would you do in this case?
Is the LV? Okay,
yes.
Got it.
Rajiv,
that's helpful because
Rajiv, I'm getting
function
opinion.
is not severely depressed and the patient is not decompensated, so it adds to the stability of the procedure here. So.
Yeah,
it also helps.
I think what is important is, again, I would agree with him.
To strategize, I think if you have a patient who's well compensated, low EDP, I think you can spend more time doing atherectomy. If someone's got a high EDP, perhaps having short runs of VT, then that's a patient maybe you want to stage things or maybe spend less time occluding the left main. So I think the idea of using intravascular imaging and then also getting some hemodynamics up front helps you decide the procedure better.
Absolutely agree with you. Our concern was that he would have a lot more calcium than we appreciated on the angiogram, which we see regularly. So we did it, like you said, we did the intravascular ultrasound. Joe, will you show the first LAD ultrasound, please?
Okay.
Can you project the IBIS?
Rajiv, if you don't mind, I'm just going to get a couple of opinions from the panelists.
Can you guys see the IBIS?
Can you hear me, Rajiv?
Yes.
I'm just going to get a couple of opinions
the
from
IBIS
the
shows about a 270-degree arc of calcium from the proximal LAD into the left main with a significant disease in the distal left main. You show the circ IBIS, please. The IBIS of the circ also shows less calcium, but at right calcium, there's significant amount of 270-degree concentric calcium, which is a little deep. So the question came up is, what is the next best option for this patient? Do we do mechanical support? Do we put a balloon pump in, Impella? What are the options? What would the panelists for this?
Okay, so
Now we have a right non-dominant coronary artery. We have left dominant system.
So I think imaging has been done. I think that's very important.
I don't have any hesitation in using an Impella. 45% EF with an EDP of 10 to me is a relatively stable patient. I might have a second.
Broke up.
I think a patient perhaps who presented, it was an inpatient, maybe in heart failure, I would consider Impella.
Salman, you are breaking up. You are breaking up in between.
Breaking up, I'm sorry. What do you think?
Okay, so
I think I'll put Impella because at this moment, patient is stable, but whatever strategy you choose, rather rotational atherectomy to modify the lesions first, or you use IVL, either way, there's the chances of, as you know, that quick decompensation. And at that time, you don't want to rush to put a balloon pump and stuff. So I'll put a prophylactic to prevent from any cardiac shock or any catastrophe. I'll put an Impella first.
We agreed with you, and so Dr. Miraj and I put an Impella in. I want to show you the video. Can you go to the video, please? We can show you the video of single access. Ray, do you want to present that?
It's on the laptop.
So how was the right coronary artery? Was the right coronary artery okay?
I keep going this way.
We've been doing most of our cases with Impella, single access.
You're good. You're good.
It limits the vascular complications.
Rajiv, how was the right coronary artery? Was it okay? There was no disease in the right? We didn't see the right.
Rajiv, have you had much luck with the 7th French? I do single access quite a bit, but it's usually just a 7.
And there, Dr. Race?
See here in the video that we're showing you, this is the large Impella sheath. The peel away sheath has been placed. The Impella has been placed through it. At one to 2 o'clock position, we're using the 18-gauge Cook needle to access the actual sheath itself. We're placing, as you mentioned, a 7 French short pentacle sheath. There are many ways to do it, as I'm sure everyone knows that it's been described. Use everything from using long destination 7 French sheaths to using short sheaths. We find that short sheath is actually very effective and doesn't interfere too much really in the actual Impella sheath itself. You can see here we remove it, and we have now a 7 French access to getting into the actual patient. So we actually today did the exact same thing, exactly what we showed you, and we have a 7 French EView 3.5 guide sitting in place. It is a little snug, pushing it through the actual Impella peel away sheath, but as long as you're careful, you can usually get it up and use it pretty well.
So we did put the Impella in. And patient was producing a flow rate of 3.6, 3.5, 3.6 liters per minute. We felt that was, like Javed said, we thought it would provide us that protection for whatever device we chose. The lesion prep was very important in this situation, given the intravascular ultrasound. So our discussion was, what is the next best option? So from the panelists, what would you guys do?
Rajiv,
just
a quick question.
IVL?
Can you people hear me or not?
Why?
Can you hear me?
I think you were able to get, that's a volcano. I mean, you were able to get a volcano across, and typically that for me is a decision point, because that typically means you can get an IVL across there. Also, it's not a complete 360 arc. I saw the maximum was about 270.
And our thought process was that
something like if it's very tight, you need a front.
Our vessel size was 4.5, and given the ratio of 0.6 for Rota we thought rota would not be a good option here, so we did not do rota. Orbital atherectomy was an option that we did consider, but our concern was that we would lose access to one of the major branches. So we did not do orbital atherectomy either, although we have used this very commonly in this situation. And we thought having a double wire into CERC and the LAD and doing IVL was the best option. Do you all agree or disagree?
Choices seems to, for me, it seems to be fine. I mean, IVL is the better way to go. And especially seeing the angulation in that CERC, rota would have, would not been a good choice, a better choice.
Our concern was the size, and also we did not have access to the LAD if we went to the CERC and vice versa. So do you want to show the iris after the first IVL, please? So here's the first post-IVL of the LAD. And you can see there's a crack in the calcium at 6 p.m. and about 8 p.m. or so. And also at about 5 p.m. And that crack was very important. And we did the same thing for the circumflex. And you see the crack in the calcium at 9 p.m. and 6 p.m. and about 11. So clearly it was a beneficial. We did 8 runs, 4 in the LAD and left main and 4 in the CERC and left main. And we thought this was the best way to assess. And I agree with one of the moderators who said, IVUS plays a huge role, because if you get the IVUS down, then I think you're comfortable that you probably get the IVL down also. Now, Bashir, do you have IVL in Pakistan?
I don't know. I have been trying to talk to you, but it doesn't look like my voice is getting to you. Can you hear me?
I hope you hear us.
They do. I'm sorry, I'm answering for Bashir. I don't think they can hear us. You're absolutely right. I think it's just the people on Zoom. But they use it selectively, obviously. Cost is a big consideration in Pakistan. I had a question.
Yeah. Rajiv, can you hear me?
Sorry, you're breaking up.
Beyond the ostium, where the diag takes off?
Yes.
Lesion prep.
That area also. In the LAD?
Yes, in the LAD, exactly. Yeah.
Yeah, that was the last one. It didn't show.
We did IVL down there also.
Bilal, I presume this was a 4 millimeter shockwave?
It goes back to the concept that was discussed earlier about, having the balloon up be as opposed to the vessel wall as possible because of the lithotripsy shock, which only goes minimal, a couple of millimeters. And so if you're not well opposed against the wall, the efficacy of that shock wave is not going to be present. So really, essentially doing it 1-for-1 is of paramount importance. And so we IVUSed, we saw a 4 millimeter vessel, and then we used shockwave accordingly. So now, how do we proceed? Would we do provisional stenting of that LAD or CERC, or would you believe in a 2-stent strategy? I think the angulation of the LAD is, and the CERC, it gives us many options. And so I just want to see what the panel thinks about the best next steps in this situation.
So, being the online panel is relatively small. Once you crack the endothelium in the CERC, I think you're committed, really. And I think, when you have such a big CERC and such osteal disease, you should just commit to maybe a 2-stent strategy up front. I mean, I'll stop there and then we can talk about which 2-stent strategy, but the fact that you've got cracks in the calcium in both the LAD and the circumflex, I would favor a 2-stent strategy.
I completely agree. I think, if you do OCT on these vessels, there's a lot more dissection noticeable than you can even see on IVUS. So I would be reluctant, given that size, dominant vessel with osteal lesion, to leave it alone.
And we tended to agree also. we felt the provisional strategy, given the also the dissection into the circumflex, we probably were uncomfortable leaving it alone. And we felt the two-stent strategy was the best option. The question is which two-stent strategy? And I think, you know, I think in 2022, after all the data from China and other places, the DK crush technique is probably the best option to maximize flow and mitigate TLR issues. So we actually thought that the DK crush strategy would be the best option. Do you all agree with that?
They're having a problem in the conference room. That was Bashir was calling, saying that they can hear us, they're hearing us an echo, but we can't hear them. That's the problem. So they're not able to interact with us right now.
Okay. So I'm not sure why.
Can anyone from Pakistan hear us and can communicate back to us so we know that you can hear us?
Can you hear me? Rajiv,
I can hear you now.
Okay, now you can hear me. Okay, so we have been trying to communicate and discuss, but unfortunately it wasn't going.
We thought you were bored and didn't want to join us.
And there's a lot of echo in the voice for some reason, I don't know why, but that's okay, go ahead. My question was that we don't have impeller, so we only have balloon pump. How many of you would be willing to do this kind of a high-risk case with low EF, left main, triple vessel with the balloon pump alone? If you don't have impeller, would you do it with the balloon pump?
Well, Bashir, if you don't have impeller, balloon pump is the next best step. It does not provide the cardiac output that you need if the patient does crap out. But, you know, we have done many of these cases pre-impella without impella, with a balloon pump.
Mm-hmm. So let me ask from my panelists. Let me ask from the panelists, like how many, Dr. Rosalie from Malaysia is here. Dr. Rosalie, what would you do in this case?
Yeah, we don't have impeller. Hopefully until the end of this year that we'll get one. But this, of course, the LV function is 45%, it's calcified and atherectomy disease, but the lesions are fairly short. We don't even use balloon pump in this case. We just make sure that we do the things correctly, carefully, and I would tend to use rotablator for this. IVL, my concern is it's only 270 degrees, and sometimes it may not be effective, or you may need more cycles to try to crack the calcium. So I'm quite curious how many cycles they actually do it. So that's from our experience with IVL.
What size impeller, what size rotablator would you use, doctor?
The minimum, the very minimum will be at least 1.75. You just want to make sure that you crack some calcium, cause some fracture, and that will probably be enough.
So I am perfect. It's a pretty tricky case, and I think perfect for the chip session. So trifurcating lesion, I saw the IOS. So from what, obviously you had an interrupted flow of images, but what I could figure out was you had a 270-degree arc of calcium, but I thought that was going into the LAD. And the circosteum wasn't that calcified. Was that how it was?
Yes.
Yeah. So I think I'll agree with Dr. Rosalie. If the LVDP was okay, probably in Pakistani setting, we'll probably have a balloon pump on standby. And I think, again, depending on what we have, I think balloon shockwave is probably the perfect option because you keep access to all the branches, and when you know it's a pretty critical lesion in both of them. So I would have probably rotablated into the LAD and then use a cutting balloon for the osteal circ and then take it from there.
So you wouldn't put the balloon pump?
I won't put it up front. I think I'll just keep it on standby.
On standby?
Because if EF for 45 and EDP of 10, patient is pretty stable. I think if you do things carefully, short burr runs, and then obviously you need to have a second access ready probably before you give anticoagulation.
Okay, Rajiv.
And you know, pre-impella, we probably would do the same thing. But I think here we have the option, and so
yeah,
just protection, given the fact that it's a less complex system, probably the best course of action for us in New York is probably pre-impella.
Okay, so go ahead, tell us what's your plan and what are you doing?
So our plan was really the DK crush technique to extend the circ, crush it with the LAD balloon, and then kiss it, and then pot, and then stent the LAD, and then repot. The question I have for the panel is, what is your thought process on sizing for POTS?
What did the IVUS show? What was the size on IVUS?
It was about 4.5, 4.9 to 4.5 in the left main.
Noman, what would you do? Pot. What size balloon would you use for pot?
I mean, ideally, if you want to crush the left circumflex, and probably at least a 4 I would start with, see how it looks. Do an IVUS again after 4 if it's been crushed properly. I'd be hesitant to go beyond 4. I know you want to get to the size of the vessel, but
Rajiv,
I mean, we do have impeller, but I think in this patient, possibly would not have used it. Even if he used it, we'll do the IVUS first, see how complex, how long will it take. And 45 ejection fraction, I think threshold will be higher. Although we don't need to perclose. We have a manta as well. But the after impeller, the groin is a problem if you don't really treat it properly. But from IVUS point of view, I think it looks like at least, as Naman said, 4 millimeter balloon at least, and then we'll take it further.
Yeah.
I mean, you can do an IVUS again after the 4 balloon and then decide if you want to.
Yeah, but IVUS is showing 4.5 to 4.9, so
yeah,
you can use 4.5. I don't think this is a problem.
Problem is when you can get the dissection in the left main as the first case in the morning, and then intramural hematoma and all that stuff as well, and rushing things. So you just have to be careful doing the perfect DK crush. So
okay, Raju, what wires you have taken and what are you doing now?
We have the BMW wires in the LED and the circumflex. We have a 40 by 18 Onyx Frontier in the left circumflex stent, and we have a balloon 40 balloon in the
LED, left main LED.
LED.
So did you use Rota? I didn't see that. Did they use?
Sheeh, we didn't use Rota because we thought we had a nice crack with the IVL.
Oh, okay.
But the hybrid approach with Rota is definitely a viable option. And I heard one of the lectures earlier today using the hybrid approach with IVL and Rota.
How good is the profile of IVL? Does that easily goes through? What size you are using? And
IVL, in my opinion, the profile is similar to a cutting balloon's profile. It is not easy to go through, but with the right lesion prep, it works fine.
Okay. But did it ever happen that IVL didn't go through and you had to balloon before or do something else before?
Absolutely.
Yeah.
Absolutely.
Okay.
That has definitely happened before. So we have now a 4018 in the circumflex. And we're taking up the stent into the circumflex artery. So it's expanding nicely, which is good. Went to 22 atmospheres.
So everyone would
now
use DK crush instead of any other bifurcate. Yeah, go ahead.
Before IVL, we always use a balloon first. If the balloon is going and a non-compliant balloon can be inflated, then we won't use IVL.
I guess you don't want to waste the IVL catheter. You want to be sure that it balloon first and make sure that you don't waste an expensive catheter before going directly instead of going directly.
Anyone would do Rota in this case? Or? Yes, Asad, you would do that?
So only concern with Rota with ostial circ lesion is unprotected LED. So that's you always worry with these proximal vessel ostial lesions. What are your thoughts on that?
Bashir, if you look at the impella, you see there's no change or no fluctuations in pressure whatsoever with the balloon up in the left vein. That gives us that protection that we really appreciate with these patients who can get sick very quickly.
I guess your habits have changed because, see, we don't have that. So, like over here, Dr. Asad was saying that he would not put the IABP and just keep it standby. But definitely
Right.
it gives you a lot of kind of a, you don't have to worry during the procedure of what's going to happen, and you can easily do that. That's
I think it gives you the peace of
comfort.
mind, but if somebody's EF is 45%, normal EDP, you know, it's an expensive device. But if you have the luxury, fine, why not? Yeah, it's a...
Najib, how often you use Impala in UK?
Not very often. I think maybe once in 3 weeks or something. Once in 3 weeks something. And then maybe in this case we might have a full French sheath in the other femoral
Yeah, the
artery.
whisper ready, please.
So because we want to put an impella after, once you put a bigger sheath in, it doesn't take too long. Computer does everything itself.
Tahir, would you use balloon pump before starting the procedure?
I would better be having a standby with a protection sheath in the left side and see, because the EDP is okay and almost systolic function is better, so it's better not to put
But the only thing is, if we want to think about putting a balloon pump in a high-risk patient, it is always better to put it before rather than during procedure.
Exactly.
Always, and that's data to show. But having said that, I still feel that this patient is not very, very high risk to put in, and I'll just make sure that I'll do it carefully. The only thing I just want to remind is, with my experience, that if you do IVL and you think that you crack the calcium, it's still important to post-dilate at high pressure with non-compliant, because sometimes you think that you've done enough, and when you put in the stent does not expand very well.
Bilal, would you use Impala before starting this procedure?
No, so in this case, I think there are a few characteristics here. EF of 45%, normal EDP, not a whole lot of calcium in the circumflex ostium, as the IVUS showed. It's such an important piece of information. And the good thing is that it's a big left main, it's straight, and it doesn't have a whole lot of length in it. So actually, in this particular case, it would be okay to, if you were to go by if you don't have IVL therapy, in the pre-IVL days, I would just put an 8 French sheath in and probably even take up to a 2, or I've done this many times, 2 to 2.25 burr, because that would be the only way for me to get really good lesion prep, and then pre-dilate that with like a 3.5 or a 4 cutting balloon. Just make sure that it expands and put it in. As long as you treat the patient with short, balloon inflations, that look, when things go down, they've gone down very rapidly. Other ways, and I think I personally, if I knew what I know now, I probably would have waited on the Impala in this particular case. But there are so many different ways of doing this complex intervention.
And honestly, Bashir, we do about 3,000 PCIs here, and in a given year we do about 100 Impellas. We could have definitely done this without Impella. Just again, the protection we get with the Impella is one of the reasons why we did it. We also wanted to show you the single access, which I think was very important to show. But I agree with the panelists. We could have probably gone either way with this. It wasn't necessary. There are many cases where you must use Impella. This is one where you may not have to use Impella. But when all hell breaks loose, you feel very comfortable with the Impella in place.
Sure. Yeah, over here the cost, if it's not available, and even if it is available, it's $25,000. So for us, it's like impossible in this kind of a situation.
Yeah. So if you see now, we're doing a kissing balloon, 12 atmospheres. And again, no change in the pressure whatsoever, and the pulsatility on the Impella.
So use the same wire to recross through the stent struts?
Yeah, we use the same wire to recross into the circumflex, but I mean, that is of paramount importance though, right? I mean, you guys all know that that double kiss is so important. And so we've done it. We have now kissed once. We have now have the stent in the circumflex. We have ballooned the LAD, crushed the stent in the circumflex, kissed again, kissed once, and now we're going to put the stent in the LAD.
So what size stent you're going to use?
One of your panelists had mentioned the LAD in the more distal proximal area. And so we're going to put a 26 millimeter stent in the LAD. 4.0, another Onyx Frontier, which is the latest generation.
So are you going to bring that like one stent from left main to LAD, that 4026?
Yep. Yes, Bashir.
Okay. And you are going
And
to
then
come into the ostium of the left main.
Yes. Maybe not all the way to the ostium, but definitely quite a distance. We'll see. Would anyone have not
That's a big. No, that's a big advantage of imaging.
circumflex and just done a provisional stenting?
Would you be worried about the distal edge of a 4 stent in LED? Why won't you use a 3.5 onyx?
Rajiv, Dr. Asad is saying that with 4.0, aren't you worried that distal LED might have a problem at the distal edge of the stent, especially with calcification for dissection? Why not use 3.5? You can easily go up to 4.5 or even 5 with onyx.
Or a Megatron is a good option, synergy they have over there. But the what was the size on IVIS of LED? I guess they know the size.
The LED was about a 4 millimeters of vessel in the LED proximal, and the left main was about 4.9.
Okay, LED was 4.
Okay.
Yes. But I agree, you could definitely use a 3.5 and just expand it to a 4.550 easily, no problem.
Salman, you were saying something?
No, I was just making a comment on the imaging. First of all, that's why imaging, you don't have to guess about the sizes of the vessels. You can actually go with confidence. And the taper. Now, the question about Megatron versus Resolute comes up in our lab quite a bit. Both of them have, really good so radial strength. Megatron maybe a little bit more, but Megatron perhaps has tighter cells. I'm not sure. So I might have gone with the Resolute just so that.
Dr. Moni, are you there? Dr. Paul Moni?
But again, the calcium burden also makes it.
What were you saying? I'm sorry, you broke up.
Dr. Doshi, are you there?
In Megatron versus Resolute, so I would have chosen a Resolute because I think you can get the cell struts much more open on the side branch. But if the calcium burden is high, that's when I would probably reach for it.
Yeah, we used a Megatron here also. It has some difficulties getting down, but the radial strength is probably a little better. But we are, our lab has all the 3 major stents, and we use Onyx, Synergy, and SkyPoint, all of them.
One thing we don't have in the US are DCBs. So I know that in Pakistan, a lot of calcium or a very tight stenosis, maybe a DCB at low inflation.
We don't have DCB in the United States, so that is not an option for us. So we're rewiring again.
We have
put the stent in the LED.
The expert and the guru on DCB, Dr. Rosley here. Would you be using DCB in this case at all?
I think that's a possibility. I think if you get good results and you think that you just want to place in a provisional stenting, that is definitely one of the options you can think about.
You would depth the circ and do a stent.
So your LED stent is going to go
if you
across
want
the
to do that.
diagonal, or you are going to enter before the diagonal?
I think it's before the diagonal right now. We may put one distal after we get off the call with you. But we want to show you the final kiss. How much time is left, Bashir?
Sorry, what are you saying? Rajiv?
How much time do we have left?
Sorry, everyone is here.
Sorry, Bashir, can I ask about anticoagulation? They're using Impella as well, and in case it's been going down. So what are they going? Are they monitoring ACT or because?
Yes, we're monitoring ACT, keeping it about 300.
Okay.
A new balloon? So we're doing the second kiss.
Which screen?
Would anyone have done a different technique like tap or
Increase the
anything
size.
else?
They're going to increase the size. It's on the side.
Take a 4 or 5 NC balloon, 12, please.
Okay, now you can see.
Can you guys see it?
Yeah,
Bashir?
we can see it. Yeah, we can see it now. The screen is bigger. Oops.
Balloons did you use for kissing, and what were your sequential pressures and simultaneous pressures for that?
What balloon?
We're doing 4015 in the circ and 4020 in the LED.
Wow.
And we're going to kiss up to about 16, 18 atmospheres on both.
And what
Again,
about,
you know, using the Miller principle, right? We use 0.67 times the 2 branches. So we're predicting about a 4.5 to 5.0 vessel size in the left main. And so we're going to,
and
after this, we're going to pot it with a 5.0.
what size you're going to use for the pot in the left main?
What do you recommend, Bashir?
5.0.
I think 5.0 at least.
I think 5.0, right? I agree.
Yeah.
And here we are, the second kiss. 2, 1, down. We take a 5.0 balloon, please.
I guess for sequential inflations, you can go up to 16 to 18, but when you're going simultaneously, generally you don't want to go beyond 12 atmospheres. So going up at 18 was kind of generous.
Yeah.
So
we are very generous here in New York. 5.015.
Dr. Rosalie, when you are doing kissing balloon, how much pressure you would use in the
Well, kissing, I suppose I don't go very high, maybe 8 to 10 atmospheres, but it has to be this proper size. But I don't know whether I miss a step, but I would take high pressure balloon in each individual sequentially. High pressure, and I tend to go 18, 20 atmospheres minimum.
Okay. Yeah, but they used 18 in both for kissing.
Oh, I see, for kissing.
Yeah.
The non-compliant balloon.
Yeah.
But they're within the stents anyway, so.
Yeah, exactly. That's right.
8. So we're going to use a 5.08
as well.
Okay. So what precautions you are taking that you are not going to crumple the stent with the guide?
I didn't hear what you said, Bashir. I'm sorry.
I think you have to be, one has to be careful when there's a hostile stent that the guide is not really
Absolutely.
pulled into it, resulting in the crumpling or distortion of the stent at the ostium.
Yeah, you can intercept that stent, I know, and it's not the right thing, but hopefully we'll be very careful when we go in, so.
Okay. So I think we are almost on time. Would like just show us the final pictures.
Yes, Bashir, one last pot and we're going to take a picture, okay?
Yeah, sure. So you're going to remove the impella in the cath lab?
Yes. Again, as long as the pressures are good and the EDP is not dramatically elevated, yes, we will remove it.
Now, are you using Manta device or any preference to your closure? You have per close, but experience with Manta?
One more time, you broke up, I'm sorry.
What is your experience with Manta device and any preferences for closure?
We invariably use pre-close for our closure devices. We do not, I do not use the Manta device, but I know that our structural colleagues use it and they're very happy with it.
We use Manta because it's much easier than per close.
Yeah.
Only because in a fully anticoagulated patient, the Manta does occasionally fail, and if it does, you have a pretty big hole. I think the structural cases, at least the nice thing is you can actually reverse the anticoagulation. So we tend to do pre-closure with 2.
Going up at the 5.0, guys, for the pot. We're going to go to 12 atmospheres.
So are you going
Down.
to do the IVUS at the end?
Yes, absolutely. Bashir, how can you do a live case without doing IVUS like several
Yeah,
times?
that's right. No, what about routine practice, not on the live case?
Say it again?
What about
Routine?
routine practice instead of the live, without live case?
So, Bashir, honestly, real world, we do IVUS pre. I don't always do it post.
Okay.
Just for time's sake, but we're definitely gonna do it today.
Okay.
You're left.
I think we might have to leave you after
Should we take a
we see
picture?
the final
Let's take a
picture.
picture.
We may not be able to
We'll
wait.
take a picture for you right now.
Yeah. Yes, please.
Can you see it?
Yeah, we can see that.
Came out
Beautiful.
excellent.
Excellent
Rajiv,
result.
Came out pretty well.
Great case.
So I think we highlighted a few things. One was the use of MCS. Two was the importance of lesion prep, which your talks have all been showing today. And really three is the options for calcium management, whether it's IVL, orbital, or rotational. We thought rotational, orbital was not the right choice here. We thought that IVL was the best choice given the amount of calcium. But we hope to be highlighted a bunch of issues for you. This is the IVUS right now live.
So can you show us the IVUS also?
Can you see it or no?
We are not seeing the IVUS, we are seeing the angio.
Can you show the IVUS,
fluoro.
Tony? Show the quad, please.
Oh, can you change?
Oh, you can
to
see
the
it,
full
but
screen? Yeah.
You see it now?
Just 1 second. I think they changed the screen. Yeah, now we can see it.
Okay.
Can we?
So here's the IVUS. The stent is well opposed. We're coming back into the left main. I think for the result, I would take this as a sell.
Yeah.
What do you all agree? Do you agree or disagree?
Yeah, looks very good. I think well opposed stent and great result. Angiographically as
Yeah, I would
well as
sell.
with IVUS. Thank you so much. Showing such a
Bashir, thank
nice
you so
case.
much and congratulations on a wonderful conference for everyone there, and hopefully next year we'll see you there live.
Yes, I hope so too. Thank you. Thank you, everyone.
Okay. Cheers. Bye-bye.
Bye-bye. Okay.
I want to disconnect. You disconnect? You guys want to disconnect?
Can we have Colonel Najib on the stage as well? Assam.
They are connecting to Oklahoma for the next live case. In the meantime, just a couple of housekeeping things. There is going to be an inauguration today for Park Live at 8 o'clock. So would request everyone, it's going to be in this hall exactly at 8 o'clock. And then we'll have dinner at 9. So while they are connecting, any of the panelists on virtually, Javed, do you have any comments, or Dr. Tunio? Dr. Tunio, you didn't say anything. You want to comment?
Great case. I sometimes, when people have anterior and inferior ischemia on nuclear scan, I wonder, because nuclear scan is based on balanced distribution of ischemia, I wonder is LAD dominant and Circ supplied more territory. So I think strategy of addressing Circ first, I assumed the inferior ischemia probably was a little bit more powerful. I always wonder though, this patient has mixed characteristics of complex anatomy and complex characteristics himself. What would they choose as post-intervention antithrombotic strategy? I assume the data would be, he's already on aspirin, so I was wondering what would they have chosen.
What kind of dual antiplatelet you would choose and for how long in this patient?
I think this, because it's not an ACS case, I might have chosen low-dose ticagrelor and aspirin for first 6 months for sure, and then clopidogrel by itself for next 6 months.
Thank you very much.
Yeah.
No problem.
Hello, Dr. Tahirkheli, can you hear us? Hello? Dr. Tahirkheli? Hello? Dr. Tahirkheli, if you're talking to us, we can't really hear you. स्क्रीन में भी नहीं आया ये भी कोई इम्पेला ही डाल रहे हाँ पता है जो प्लस से ज़्यादा पैसे मिलते हैं नहीं बहुत ज़्यादा है इम्पेला की रिइंबर्समेंट $120,000 एंजियोप्लास्टी की 20,000 बहुत नहीं इम्पेला की रिइंबर्समेंट ऑलमोस्ट द सेम एज कैबल तो इसलिए तो हर एक में डाल दें
Dr. Tahirkheli, can you hear us? We can't hear you. टीवी डाला हुआ है
उनको फोन करो Dr. Tahirkheli, can you hear us?
We can hear you very well.
Perfect, we can hear you now.
Oh, okay. All right, so hi there, we're here from Oklahoma City, Oklahoma Heart Hospital. Let me just introduce you to the people that are with me. We have a complex case going on here. This patient is about 78 years old lady, 55 years history of smoking, diabetes, hypertension, hyperlipidemia. She had a major infarct about 6 months ago. Left mid was occluded at the time. She got a stent placed at that point.
Was in coma for a few days and then came back and did fine.
This was down in Texas.
So she came in with unstable angina, came to the hospital, and we got a
Three days. And then just for this conference.
we've actually kept her here for 3-4 days so we can do it live. We were waiting for you to do all of this in front of you, but we had to get going. So let me just introduce you my panel, and I will tell you what kinks are going on and what's happening. So
I have with me is Dr. Kevin McEwen, who's our
anesthesiologist. The patient is under general anesthesia. And then I have with Dr. Haider Ali. He's from 2005 GAE graduate, is one of our partners. Dr. Naveed Ahmed, Liaquat National, he's been my partner for almost 20 years now. I have back there Brad on the scrubs, then Alyssa back there who's circulating. Did you guys hear me?
Yes, we can hear you.
I can't hear them.
So, can you hear us? We can hear you pretty clear. Can you hear us?
No, it's not crossing. Yeah.
So we can hear you very well, Dr. Tahirkheli.
Unmuted in there.
We have a full panel of experts here as well. We have with us Dr. Bashir Hanif, who is the moderator for the
Start
session.
facing.
So I'm just going to introduce our
Hang
panel
on,
as well.
Start facing, Kevin. Not yet. Start. No, 180. Face. Okay, go. Okay, fine. Stop facing. Stop facing. Let's do that one more time. Just 1 second. Okay, go. Stop. Oh, yeah, I got you. Let her recover. Why don't you pace her? Can you guys hear me?
Yes, I can hear you. We can hear you, sir. Can you hear us?
I can't hear you.
You can.
So, some of our observers from Pakistan.
So, Sarah is from Dow, and then Arsalan is from Rawalpindi Medical College, Qasim is from Allama Iqbal Medical College. They're here doing rotations, observing, hopefully getting into residency next year. So this is, let me show you the angiogram, but what really was going on was proximal to that left main stent, she has an ostial 99% stenosis. So typically we would, this is not an elective case. For this conference, we just kept her in the hospital for 3 days or so that we can show it to you live. She also has moderate to even worse aortic stenosis. Her mid-LAD has a very tight calcified lesion, bifurcation sort of, and then her right coronary artery has about a 70-80% very calcified lesion. So the plan today was going to be to see what you guys think, but since we were waiting, we've opened up some of the equipment and we'll show what we're doing. So it actually took us a little while to get into the aortic valve, and then it really don't have a good support there. So I ended up doing valvuloplasty so I can get my impella in, which is the plan to do. That's kind of where we are right now. So we're still trying to figure it out. I can't hear you very well, so we'll figure that out. Let me do the valvuloplasty. We'll get the impella in front of you, and then I'll show you the pictures. We figure out the.
Thank you, Dr. Tahirkheli. We have a full panel of experts here as well. So we have Dr. Bashir Hanif, Colonel Mujib, General Farhan Tayyib, Professor Hafizullah, Dr. Najib from UK, Noman Nasir, Dr. Rosley, and Dr. Tahir Sagir.
You can see that it's so angulated and tight that I'm having a problem getting my balloon across, which typically that meant that it would be very difficult for me to get impella in. Okay, start facing, Kevin.
Negative first.
Yep.
Dr. Tahirkheli? So you said it's moderate to severe aortic stenosis.
Okay, good. Stop. All right. All right. Now you're going to have to start. All right, hold this. Let's get that impella in real quick. Give me a picture of that real quick. Pressure is about 64. You guys can see that?
So it looks like what they're doing is it's probably a case of complex CAD with moderate.
EF is low normal. LVEDP today was 31.
So it looks like before doing any complex angioplasty, most centers would prefer doing a BAV.
EF is down. Go ahead and show that
That's what
echo over
they've
there.
done. And also BAV is going to help to put the
Since we went to doing valvoplasty, I asked Dr. McEwen to actually quickly put a TE probe in there. Again, these are things we don't have to do. We're all of us here. We're doing a conference, so we're doing some of the stuff that the daily things may or may not do. Okay.
So now they're swapping the wires. So the wire that they had for BAV was a 018 stiff wire. So they're putting a pigtail in there. And inside the pigtail, they're going to put the impeller wire in, which is a much thinner wire. That's the wire, impeller wire going in. And then on top of that, they're going to put the impeller in.
Can I see the T on? Are they connected? They may not be connected to me. No worries.
Okay.
Anything on the sound? That's okay. Anything on the sound? I can't hear them still.
Yeah, can you hear us now? So what they're doing is impeller device itself is like a pigtail. So the wire actually goes in through the front hole of the pigtail, but it comes out through a specific port. And what they were trying to show was that it comes out through a marked port which has a red tag on it. So those are
Go
just
down, hold this. It's not going up easily.
when you're putting the impeller in.
The wire.
Calcified, huh?
You can see that it's very severely calcified there. And the impella is having a hard time going through that. So remember, we're going over.
Maybe it's a case you can use IVL.
Almost an 018 wire, so it makes it a little difficult. Let's go.
Yeah.
Let's take it out. Can I get the long sheet? This. Huh?
T. Dr. Tahirkheli, can you hear us?
Put the sheet on top of it.
Yeah.
So I think probably what they're trying to do is they're going to put a second sheath inside that impeller sheath and put a stiffer wire in there to maybe straighten out the aorta so that they can get the impeller up.
All this?
I said the question was, So the sheath, long sheath they're putting, and how that's going to help with the impeller course go up. Can you explain that?
So the bigger impeller sheet, so impeller comes in two sizes. The bigger impeller sheet can allow actually a second wire access. So what you do is through the seal part of the impeller sheet, you make a second hole, which they showed in the first case. Can you hear us? Yeah, so I think what they're doing is they have made a second hole in that impeller sheath and putting a stiff wire alongside it to probably help them to track that impeller, because remember, this impeller goes on a very thin wire which doesn't have that sort of support to get it through that sort of a calcified lesion, and impeller itself is very bulky. So I think that's where they're struggling.
So they're just talking about
Buddy wire, I think that's what they put a second sheath.
The wire part we got, but the extra long sheath, how is that going to get the, what was the purpose of that?
The extra long sheath is not the impeller sheath.
No, it's not that, but
the sheath.
But I don't know where he was putting that. We don't know.
So give me a 2.5. Let's see if that goes through.
So they're downsizing the actual impeller device from impeller CP to impeller 2.5.
Can you tell the difference in profile of both?
Difference. So
yeah.
impeller CP is a 20 French system. And
so this is not going through. I'm going to try a 2.5. That's a little smaller size. See if that goes through. You can see it's a porcelain aorta. Very severely calcified here. It's calcified everywhere else. While they're opening up, let me show you the angiogram.
So what's the French size difference between the two?
18 and 20. 18 is for the smaller one. Huh? But it's still, if it's just an angle, it might just get it through. Calcified. It's
you can see that there's a stent in the left main, and just the ostium is about 99% stenosis. So when I engaged it, the blood pressure was 160, and it dropped to about 70.
So very routinely in structural cases in
so you can see that a little bit more, the ostium.
The aorta to get the valve up. So we could have used an IVL here. Peripheral IVL is FDA approved.
So right here, you can see that ostium is like 99%. And this is the LED. So pretty bad all around.
Yes.
Now most of my stuff is actually in the distal aorta. So peripheral IVL is not approved for aorta.
Yeah, true.
But yeah, that is one of the thoughts when we have iliofemoral stuff and we can't get our structural heart things, we do that. But this obviously is in the distal aorta. So. Okay, let's go there. Any thoughts?
Can you hear us, Dr. Tahirkheli?
So we can hear you.
You cannot, or you can?
I can.
Perfect. So we were wondering about a buddy wire situation. Like, is that what you were thinking of when you said the long sheath? We couldn't hear you after that. When you were still trying the impeller CP to go up.
Sorry?
When you were still trying for that impeller CP to go up, and then you said something about a long sheath. So we lost you there a bit. So we were trying to understand the thought process.
Yeah, so the sound is a little patchy, but so what happened is the impeller CP wasn't going up. And so I put a longer sheath in to see if it go through that.
and that didn't work. So we've now changed out for Impella 2.5, which is the smaller version of this. We can see if that kind of works or not.
So you changed the sheath to a longer Impella sheath on the Impella wire?
Yeah,
Brave.
I did. I didn't want to lose my access there.
Yeah, fair enough.
So, but the Impella, the long sheath has a very tapered dilator.
Yeah.
So it does have support. So okay, we're going
Perfect.
through there.
That looks good.
So Oklahoma Heart, we've got about 55 interventional cardiologists. We've got a little mini Pakistan here. We've got about 15 of us are Pakistanis.
That's great to know.
Some of the senior guys came in and we hired a lot. So got a little apna going on over here this morning.
So while you're doing this, would I get a couple of our own panelists to discuss what strategy would they use for that?
Yes, please.
Left main? Perfect. So, Dr. Rosley, what do you think?
I would definitely pre-dilate first to allow flow, and then imaging is, I think, very important to decide.
Okay, give me the attention long sheet.
What do you think with that mid-LED lesion as well? What would be your? It looks clearly very calcified.
Yes.
So which one? What's your preferred atherectomy device here?
Well, preferred in this case is going to be fast, and is going to be an rotablator. Definitely.
And then that ostial circ. What do you think about that?
I believe it's going to be calcified as well. Yeah. So if it is, then again a rotablator. So trying to save cost, and it's quite quick and much faster and more controlled than OS.
For ostial circ? Ostial left main. Probably, I think in this case you might have to actually do it as well on top of rotablator. Yes. For Hansa?
Strategy as outlined by Dr. Rosley. I think we have to predilate and rotablation, of course.
For Hafizullah sir, what do you think?
Upfront rotablation.
That's sensible. That's the way to go.
Dr.
So because the aorta is so tight, I went ahead and put a long sheet so I can get my guide in from the right side. And as you will see, it's extremely important for me to have a really good position in the ostial left main and just be able to park it right outside. So the longer sheath is in. Okay. Can you fix this?
I think
like
Rota
it's
is
falling
right.
off.
I don't think cutting balloon will work. I think Rota
What
is the
about this
quickest option here.
Yeah, Doman.
I guess balloon first, and imaging if you can with that. But if the patient is stable, then go for Rota.
Tahir sir, would you balloon first or would you just go up front with Rota?
I think better to do a pre-dilate and then rotablate with a smaller bar and then upgrade.
But yeah, in this sort of heavily calcified lesion, you have to always have to bear in mind the risk of a dissection with an NC balloon, and then Rota becomes challenging, especially if you have a side branch which is that heavily calcified and angulated as well. So maybe, yeah, I'm sure there are multiple ways to skin a cat, but like...
Yeah.
Actually, for that reason, I was thinking of talking balloon.
First,
a little more LAO.
Yeah.
One question, Asad, if I am allowed, for predilation of the aortic valve,
yes,
they are doing. So they do routinely for tricuspid valve or bicuspid also?
I think luckily or unluckily, bicuspid valve is not that big of an issue in US. So that's why we routinely, in a severe aortic stenosis case where you're going to do a lot of atherectomy, we would always pre-dilate. And for a bicuspid valve as well, obviously we know the risk of aortic regurg and stuff after that. So it's always a challenging decision. But for this sort of a calcified complex case, I think if you have a tight aortic valve, you probably are better off dilating that before.
Give me the what?
Yes, indeed. Yes, indeed.
Okay, pull back.
Sorry, sir, can I ask? I mean, I still don't know about this
Speaker or not?
transesophageal echo. If
You gotta
you're
work on
worried
it.
about the aortic valve, patient should have the CT aorta first, and then
Yeah.
you go for it. It's electric case. And then putting it into GA with another transesophageal echo, I'm not sure. I mean, that's the...
Usually these patients are being worked up for TAVR, so they would have had a CT done, and on that you would have appreciated the aortic calcium.
And then especially if you're thinking of impella as well, with the TAVI, you have an access, you know about the access point of view as well.
Yes. True.
And rota, I think, is still first. Try to avoid ballooning here, because if you have a dissection, you have a problem. So
Yes,
I think rota
exactly.
will be quickest.
So can we have the panelists on Zoom chime in as well? Can we have the screen with some panelists?
Okay, give me a picture.
Bilal. Dr.
Right, hang
Bilal.
on.
I think in an osteal lesion is probably one place where I feel that orbital atherectomy does have a good role. The challenge with the rotablator can be that getting the guide catheter sit coaxially, and then because with the orbital atherectomy, you can actually do a retrograde ablation as well, which you cannot do with rotational atherectomy.
Yeah.
So in this case, I think, my feeling is that orbital would be a pretty reasonable thing to do. I agree that after that, you should at least do a predilation, and if imaging shows that there's severe residual calcification, then certainly,
Let's see where this best picture is.
that I would start off with orbital atherectomy here.
Yeah. Pretty significant calcium. And
Yes.
Dr. Salman, are you there
Okay,
on
test.
Zoom with us?
Brad. Hang on.
Are you talking to me,
that?
Asad?
Yes, I am. What do you think, what would be your strategy here?
I mean, you need to do some kind of atherectomy. I mean, what would... Here, I would have done rotational atherectomy to start with, without dilation. Of course, we don't want to cause any dissection and then have our limitation. So, rotational atherectomy will be my choice.
Yeah, it's not really sitting. So, Dr. Tahirkheli, a question for you. How well is your guide seating there? Like, it looks like it's not really seating
The
very
issue
well.
is we don't deliberately want to. So I'm trying to be outside, but when we're done, kind of trying to get in there while we're sitting outside. That's why we actually do not do a single axis also on the outside and single axis because we wanted to be able.
What he's trying to do is trying to fish for
outside
the
in the aorta
osteal, because if
and
the
try
catheter
to
gets
get
engaged
it
in there, they can be sudden drop in blood pressure.
In regards to
although we have impella, but
osteal,
still
the CSI we can come back.
it may take some time, but once it
But
crosses, it
I feel
makes the job
more
easier.
comfortable with rotablator and done tons and tons of these osteals where we can actually go out, start from the aorta, go in, and it centers itself being centripetal. Okay, so while you guys talk, I'm going to try to get in here for a second, so just give me a second.
Question, like, do you
That's
ever
all.
make holes on your left guides for these sort of complex PCIs? Just to get the pressure reading a bit. Just for the pressure, because it's damping. Oh, yeah. No, but still, it's just a general question.
I mean, I don't think it really improves the flow to the coronary. It's just, it makes you feel better. The
Makes you
tracing is
feel
good, but you are actually
It
falsely,
develops
yeah.
like a
Yeah.
Oh.
Right comes with end hole,
And you
but
test?
left guides don't come with side holes.
No. Okay, go back.
Chitkins,
Okay, we might need a
because of that
different guide. But let me try this one. No. Go.
Catheter is too far back.
Almost there.
So what wire are you using there, Dr. Tahirkheli?
We went in with a Sheeh black. I knew this was not going to be a simple thing, so.
Yes. Very complex. Very.
But the idea was I wanted to do that this in front of you because a lot of times when we've already done it, you don't see the struggles that we're going through trying to get all this. And there's a lot of learning for the fellows in this part. All right. Okay, let me try that. And you take over the guide.
Yeah.
Let me have the floor.
Very tough case to do with the light. कुछ नहीं बताया. Moderate. कितनी? 45? 31. आज 31 बताया. आज 31.
So we kind of expected this, so we have a microcatheter in place.
So what microcatheter are you using? A supercross for angulation or just a straight tip one?
No, this is just a standard turnpike.
Okay.
Give me a little test there.
Nice.
Again.
Stick it in the tablet now.
Give me a little test there again.
So would any of the panelists change the wire to something else, Dr. Rosley?
I mean, my normal workhorse wire would be either run through or a Sion, but in cases like this, I would tend to use a polymer jacketed.
Okay, come over here.
Polymer jacketed.
Now the problem with
XT,
the keeping the 3.5 is now I don't have any support. If I push it, it's going to come off. So, give me a bigger test.
Sion is a good choice here because
Sion black
it's a soft wire with some hydrophilic coating distally.
Yes.
Okay, hold the wire. Hold the guide.
So Noman, like, is this the guide that you would have chosen, or would you have gone in with a different guide?
I think it's the right guide with the ostial left main. You want to go with the Judkins. You want to keep it disengaged the way it's doing. Otherwise, it's going to be a problem.
But do you expect this guide to give you much support once the wire has crossed? Like
that's going to be an issue, definitely.
Unfortunately,
yeah.
that's
Yeah.
the bail.
But I don't think you have a choice. Yeah.
There's a downside to it.
But you'll be wiring the circ, LED, and hopefully the wire support.
Okay. All right.
Yeah, I'm not sure you need a huge support here anyway.
So give me another wire.
No, I think mid LED is also pretty tight and calcified.
Just you can give me a choice floppy or
You may have to start dilating with a very small
We'll
balloon.
cross the bridge when it comes.
Yes, exactly. We have to get into the bridge first.
I think he may have to start with a very small balloon, like maybe
give
1,
me a
1,
choice
1,
floppy
2,
TT or a
sometimes for me,
one by one.
very poor support. I think you need support to get through because you need to pass the microcatheter down. I can still use an XV or EV. It's just that in cases like this, I just have a 3.5 wire just to go outside the soft part. So it's like a protection, and we don't jump into the left main, and then from there you wire. Once wire goes in, then you can actually take it out.
That's what I was going to suggest. So we have used
and see if I can get
Voda left
inside.
side, which have a soft tip for these sort of lesions.
Can I use this?
Yeah. Get another Parker from there, boss.
This is very soft. It's a Boston guide. So
Yeah, the Pilot 200.
you're going to get some damping, but at least once you are across, and then it gives you a good bit of support for the rest of the procedure. But again, like you cannot. The right answer is probably Judkins that we are doing.
Judkins with a short tip.
Short tip.
Yeah, short tip Judkins.
No, you can actually keep it out of it.
Would you use rota if you need to do a rota on ostium? Because it's too soft at the tip.
Yes, it's a very soft tip, so you can always disengage it a bit, and you can always start rotablating from inside the guide.
But you become coaxial very quickly.
So
I want that,
a lot of time you would go AP caudal or RAO
Call it
to make
200.
it coaxial and then do it from in that.
Got it?
She's
All right.
Wire. The wire. So, Dr. Tahirkheli, what are you doing now? We see one wire is across. Looks like maybe in the diag or something.
Sorry?
So we were just asking what's your thought process now? You have one wire in, looks like maybe in the diag. So you're planning a second wire in now?
Yeah, so what I think has happened is I went under the stent strut.
Okay.
But it's very hard to get a guide position. So I have this wire in, so that allows me a little bit of some support to keep the guide in there. And I'm going to use that and try a different wire and see if I can get in within the lumen instead of outside the. Okay, I'm going to pull that turnpike a little further back because I think it's just kind of directing me a little bit.
And the second wire you have taken is Sheeh on black as well?
No, I took a Pilot 200.
Pilot?
200.
200, okay.
Looks better.
Dr. Tahirkheli, what do you think? Would you do anything different at this point? Other than changing the case?
Maybe we can use a over-the-wire balloon, the old one, over-the-wire balloon, and use a fielder FC. I would go with a fielder FC with over-the-wire balloon with a lower profile. Maybe.
Oh, remember, we have an over-the-wire balloon already. So we've got a turnpike in there, which is essentially like an over-the-wire balloon, maybe even better than that at this point. I don't want to dilate under that stent.
So, any point in using a twin pass or something, maybe to put the second wire just before where the stent starts?
Yeah, the biggest problem is the ostium is 99% steno, so I have to get into that.
Yeah. No, we are all admiring the choice of the case. Like, it's a very tough case to do as live case. So some of the panelists think maybe Fielder XT might be a wire that you want to try if Pilot 200 doesn't work for you.
Fielder FC.
So the turnpike didn't go all the way down? What,
no, it's not going in.
So he's just trying a different microcatheter to get
it's not a problem of the wire. I just,
it's not the wire, yes.
I know I'm stuck. I have no support. So either I just start over again or use that to try to see if I can get this. So I'm going to try this strategy. If that doesn't, we'll start all over again and try to cannulate that again.
So just a question, would you consider a different guide at this point?
That would be the next strategy, absolutely. But I clearly got in.
With this.
Second wire is to just get support to push the microcatheter in. And
I think they're saying the first wire is anchored behind the stand, so it's at least keeping the guide placed to the ostium. Easy to go. It's not proving very easy. The problem is not just the ostium, there is disease after that as well, so that keeps deflecting your wire.
It's not the disease, it's a stent that's in there.
Angle, yeah.
And that's pretty diseased too.
Yeah. How old is the stent, Dr. Tahirkheli? How old is this stent, Dr. Tahirkheli?
Okay, give me a little test there. Okay, I'm going to take this introducer out. And now that I have two wires, we can suck this in a little bit more. And dilator in there. Give me an introducer dilator. Give me a picture there. Bigger one. Let's take a picture. Yeah. Introducer dilator here. Okay.
Looks good in the circ, at least now.
Okay. Ready? We can take another picture there. I'm going to be able to see where I am. Inject.
LED. Good.
One more time.
Okay. Let me get a trapper. So we're going to take the other wire out altogether. Hang on. Hang on. Just take this, all of this out. We're done with
So
this.
that's great. So what's the plan now?
Give me the turnpike on that side.
Turnpike's out.
So can you show it here? So I'm going to use a trapper. I've got a short.
Okay, you talk to them.
I've got a short. So Dr. Ahmed is doing this. So we got a short pilot 200 that we went through. We've got it in a good position. He's going to put a trapper in there.
Okay.
It's a long guide to pull that back.
So you're using a trapping balloon to keep the wire in place while they take the microcatheter out.
Sorry?
So you said you were using a trapping balloon. Is that what you were doing?
Yeah, let's show you that.
Yeah, people use different techniques.
So,
Turnpike. Yep.
up there, and again, a lot of you guys have used it. Some of the fellows there may not have. You can, that's the trap balloon in the guide. That's inflated, and that's holding my wire. And that way I can actually take the turnpike that's up here, show it there.
Yeah.
And I don't have to have a long
Way
wire.
to do it when you're,
We do a lot of CTOs and use trappers all day long and just hate using very long wires. It just makes for a very, very busy back table. So the wire went across that. We deflated the trapper and he's got the balloon.
So just for the juniors, the thing that they need to make sure is that the
that over there?
microcatheter is behind the balloon, like, so it's always has to be distal and the trapping
Okay.
balloon has to be more.
Brad, you got the wire?
Yeah, we got it.
Or Heather, you got the wire?
Yes, got the wire.
Okay, you got it? I got it.
And use the trap balloon according to guide catheter size.
Yes.
You know, if you have a very small balloon, then it's just a false security.
So at least a 2 or 2.5, depending on what
Now
you
you-
6, 7, 8 French, whichever.
If the wire doesn't cross and this is narrow, and you have crossed the main
You can cut.
You think the second one went under the stand too? That would be special.
Afterwards, yeah. Some pressure. Yeah, so that at least you
try
can
this.
engage the guide and stuff. Exactly. Yeah. People do it all the time. Huh? Always inflate, get the pressure down.
Yeah.
No, no, people do it already, yeah. So, Dr. Tahirkheli, what's the plan? Are you going to use NC balloons? I'm sure you're planning
No.
something
So
else.
I'm going to do a rotablator. Once I get my turnpike through, I'm going to put a rotafloppy wire and we're going to do rota. But it won't go. You'll lose the support there. Okay, get me another wire. We're still under that stent. So look at that very carefully. See, I'm getting under that old stent, and so it won't let. Stay at 15, guys, so they can see it better. 15 frames per second. So, Bashir, do you guys have different exposure settings? Do you go to 7.5 or 15 or 30 frames per second? Have you guys put in that software in in your cath lab yet?
Yeah, we have the 7.5 setting in a lot of cath labs, and a lot of EP people use those settings. But I think coronary people mainly use 15 and 30s. If I'll ask the panelists as well.
So for the fellows who are going to be doing a lot of this, and we were naive when we started 22 years ago, I would really suggest getting used to when you have long cases, knowing what your frame rate is, what your AK is, and watching that very, very carefully. Dr. Irshad Mahmood is one of the course directors for this, and he does obviously robotic stuff. I don't know
that's totally
if that's available anywhere else. I certainly don't have that available, but radiation is a real thing, and we just need to have all the access to these tools of going to lower frame rates and stuff. And it's just a software. It's not very expensive to do.
Yes. So, Dr. Tahirkheli, we have 10 minutes left on our end.
Just frame rate point of view, yes, 7.5 sometime actually is not helpful because you do longer runs. Okay, so we do use EP people like it, but we still go 15, and be careful about
We just want to get.
That's more important for us.
So I got into circ test, and I think let's redirect this and see if I can.
Yeah. So we have 10 minutes left, Dr. Tahirkheli. Good.
Would you consider a change in strategy given the difficulty you're having with the guide support and even delivering a microcatheter to just pre-dilate the ostium and treat the ostium with IVL, and then at least get a more aggressive guide catheter that will help you treat the more distal lesion?
But they cannot get.
Yeah, I think that's pretty reasonable. We have IVL here, I've got the CSI here, I got rotational atherectomy. Because we were late coming on, so I opened up the rotational atherectomy. But I think that's a very valid point you do with that. Test again. Okay, so we're going to change out our turnpike and hope that we can get across here and get going. Okay, trapper again.
You got the wire?
You want to take this out? Yeah, we can take that out. That's fine.
So, Dr. Tahirkheli, do you use a specific trapper balloon or any compliant balloon size to the?
So, yeah, you can use any compliant balloon, obviously, just like you said. You can use it depending on the guide.
They are marketing a trapping balloon.
7.5 or 3.0, and that'll work that way. We use trapper balloon. It's a little more reliable, and it's very compliant. So you can use it for 6, 7, or 8 French, the same one. And if you use the regular balloon, if the compliant balloon, that gets messed up after 3 or 4 inflations. This one just kind of stays pretty well. So, but that's an extra expense both ways. Go ahead.
Yeah.
Oh, so we've inflated the trapper again up there. I just wanted to say hello to all of my colleagues in Pakistan. I think Amber is probably there somewhere. Tariq Shafi is probably there. Tayyab and Jauhar. And so hello to everyone. So we got to use the trapper.
We're running short on time.
Now we have the.
Unfortunately.
Okay.
Got the wire?
Got the wire? Okay.
Tomorrow.
Use that furnace. Huh?
Same problem, but I think let's use a 1O balloon like we were going to do.
So, Dr. Tahirkheli, we might end up losing you in a couple of minutes because
Okay.
we're running out of time. So, maybe we can see the final images tomorrow. If
Yes,
you will
that's
be
great.
kind enough to save them for us.
I'll just WhatsApp them to Bashir, and he can show you guys.
Perfect.
Tomorrow is Saturday. We won't have the staff here.
Yeah. Okay.
But yeah.
Perfect. Thank you. Thank you very much.
Thank you very
A
much.
very brave case to do as
Thank
like this. Perfect. Thank you.
Okay.
What?
All right. Let's do the 1O balloon.
So I think, thank you, Dr. Tahirkheli, from all of us here. So I'm gonna.
Yes, sir.
The final, what's their plan, final? It's okay. But I think it was good to see the impeller being used in two cases, and then I think we need to be aware. If you don't even have it today, then I think impeller is going to come gradually.
This case needed the
definitely needed impeller.
So this was a case I don't think anybody would do without impeller.
Okay.
Yeah, I agree. But what's your experience? Is 2.5 adequate for a patient like this, or you still want to try to push for
I
CP
think 2.5 is usually enough. Like
Is
if
it
you have
enough?
been here for
Yeah.
45, 2.5 is pretty good.
But I gather the company is going to stop producing 2.5.
Yeah, they want
and-
us to 3.5 in the 5,
Yeah.
which we use for the right. Perfect.
The other port runs.
Thank you. Thank you to all the panelists and thank you. Great case. Okay, so just you want to announce? So everybody needs to come back for 8 o'clock inauguration of for the 8 o'clock inauguration ceremony because everybody is going to be here. नहीं नहीं लेकिन I have heard of you a lot from Azim sir. Azim तो मेरा बड़ी है. हाँ
कुछ आ गया.
मैंने सारी अच्छी बातें आपके अंदर सुनी हुई है माशाल्लाह.
That is good.
Good man. First class.
Thank you.